This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, a cardiology specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to MyHeart.net, and today we're going to discuss women, heart disease, and the need for better research and treatment. And with us today, we have Dr. Nicole Lohr, who is Division Director of the Cardiovascular Disease at the University of Alabama. She's also Professor of Medicine at the Hersing School of Medicine at UAB. She's the Mary Waters Chair of Cardiovascular Medicine. She's also involved with a lot with the American College of Cardiology, and currently this year, Chair of the ACC Board of Governors. So Nicole, welcome to MyHeart.net, and thank you for your time.
Alain, it's so good to see you, and looking forward to our conversation.
Thank you. We know that cardiovascular disease is the leading cause of death among women. However, women are consistently underrepresented in clinical trials. Most of the studies are done in men, and the results of these trials are just extrapolated to women. Certainly, women are not smaller men. So, Nicole, tell us a little bit about some of the history about women's participation in clinical research, and what's the current status? I mean, are we enrolling more women in our studies?
Well, I would say the current status is we're more aware, and we're trying to enroll more women. And I think the take-home message that I would share with the audience is for those of us who are women, we need to increase our participation because we have a long way to go. And I think largely this is because historically we did kind of think of women as maybe smaller versions of men, and sadly incorrectly. I think the other is, if you look at the history, and you and I have both had an opportunity to look at some of the articles related to that, there was oftentimes concern, are we protecting women by keeping them out of clinical trials, especially women of childbearing age? So when I looked at one of the articles and read that, I thought, wow, this is crazy. But 50 years ago, there was a benevolence, keeping women out of clinical research. So I think we've come a long way. We've had some incredibly great women's health initiatives, thanks to Dr. Bernadette Healy, who started that. It was some of the first data that we collected about really what to do with estrogen replacement after menopause. I mean, these trials were truly foundational to the way that we have treated cardiovascular disease and cardiovascular disease in women. And so that wouldn't be possible unless we were able to generate various cohorts of women for observational trials. I think of the nurses' health studies as well. So there has been a recognition that we need to do more research in this area, and largely the trial participation in those points are really, I would say, observational. Okay, I'm a woman, I'm gonna be enrolled, and my mother-in-law actually was enrolled back in the day. And yes, it was really funny because I remember being in college and she would get a phone call, oh, I have to answer these questions. Well, a survey is great, right? Tell us what happened to you in the last year, any new diseases you've developed, what medications you're on, how much sleep you're getting, I can donate 20 minutes or a half hour of my time every year to a trial. The difference becomes when we need to test new therapies or new interventions in women, and that series of investigation is a little bit more time consuming, and that can sometimes conflict with the very busy lives that women lead. And so I think that's one of the larger barriers that we have in trying to enroll women in clinical trials.
Tell us, Nicole, why is it so important, to to have women enroll in clinical trials? I mean, obviously they're not men. There's all this hormonal environment, and it's so different. We need to know how these, drug works. It may be completely different.
Well, absolutely. And I think about how some of the fundamental hormone mechanisms that aren't even related to our sex, right? I think of the renin-angiotensin aldosterone system, which is fundamental to blood pressure regulation. We have numerous levels of therapies at all different points in that pathway that can target the system and reduce blood pressure. And yet estrogen also um, will act in that system. And so we know that we've seen women with differences in renin and angiotensin levels before and after menopause. So it is important because we are different and there are sex differences, and even within the makeup of again common pathways both sexes share, you can see genetic differences. And so I can't always predict how I will react versus you will react if I take a medication. The other thing I will say is that the side effect profiles and how tolerable those drugs are also different, and it isn't necessarily related to size. The way that women versus men can deposit subcutaneous fat versus visceral fat, and how drugs are absorbed in fat versus muscle are different. That can speak on some level to maybe some of the side effects that I may have, and as well as what's the proper dose of the drug that I should be taking, right? So it isn't just we'll take a lower dose. It may be I might need a higher dose. I mean, most of the time it's a lower dose, right, to hit the same level of efficacy. But unless I do the trial, I would never know.
Yeah, so interesting. We even see in case of beta blockers or ACE inhibitors, benefits that we've seen with ARNIs, in HFpEF in women, where it was not present in men. The response to resynchronization, when you have heart failure, women respond differently. So women engagement is so important because the therapy is really not the same. So what do you think, what are the solutions? How can we increase participation of women in our clinical studies?
Well, I think the first solution is really what we're doing today. So I want to thank you for even raising the topic and sending it out into the heart community. Those of you who are listening to this podcast now have a little bit more education that it is important that you participate in a clinical trial. And so education, I think, is really critical. I think that the work that is done on a national and regulatory level through the FDA, the National Institutes of Health, as we design as clinical trialists, we have an obligation to ensure that we have defined how many women, how many various groups of people need to be tested or studied in order to recognize what the appropriate dose is or what the side effect profile actually looks like. And so the more we have conversations with our regulatory agencies and our funding agencies helps us. And so I have really witnessed within some of the sponsors of clinical trials a renewed interest in making sure that they're looking at all groups. So women would be included, as well as other racial and ethnic groups, in order to make sure that trial participation models what America looks like.
That's so important. I've had a lot of issues with enrollment age, or when in the inclusion criteria, a lot of times clinical studies stopping, at 80. which is a problem because, I mean, obviously, women, tend to outlive men. So you're more likely to, enroll number of men just because of some of your age selection in your entry criteria, possibly. And we're starting a study, which I think is going to be very interesting, on factor 11 anticoagulant. One of them is milvexian. And there is no age limitation. And I think this is really wonderful. I mean, you can enroll a 85-year-old, 90-year-old, and I'm hoping to enroll obviously more women, and maybe we'll reach more than 50% enrollment in women in this kind of trials. I hope we have more like this.
Oh, I can't agree with you more. If the expectation for most Americans is that they will see 90, am I going to stop treating that person at 85, 87? I mean, we're providing life-saving interventions, and I think and you mentioned this earlier at another time about look at the partner trials for transaortic valve replacement. That was a population of people who were by definition too frail to undergo surgery, open heart surgery, and therefore those patients tended to be much older, some into their 90s, and more frail. So the actual population of people we need to study more. And so we want to talk about women in clinical trials, but we really need to also talk about the real aged, because the expectations of most Americans is they're going to live a lot longer than 80 or 85.
Yeah, and we have no data.
We have none.
Yeah, we're treating these patients every day and more and more. I mean, I used to think that 80 was old, but it's not. I mean, it's, people are still having, healthy lifestyle. They're playing golf, into their 90s. And, they're still, now they're raising their grandkids,
Mhm.
a lot of times. So, this is a very important patient population group, great important demographics that, we need data, we need enrollment. And by increasing, I think, the inclusion, the age at inclusion criteria, as well as maybe, increasing the participation of younger women, even that are in reproductive age,
Mhm.
would be important. I mean, we treat these patients in our office every day, yet we have very little data, of the drugs that we're giving, like statin or beta blockers or, or medication, antihypertensive medication. So,
No, I mean, you raise a great point because a lot of the indications of why we don't use certain classes of medications were largely done in pregnant animal studies. And so for us as clinicians, you and I will see women who are pregnant with cardiovascular diseases, and everyone kind of starts to scratch their head, really what's the most effective way of um, treating these women, and are we doing a disservice to them by never trying to find alternative ways of treating their hypertension or diabetes and their heart failure. I mean, some women have peripartum cardiomyopathy and they want to breastfeed and they want to do all the other things that we would say are healthy. And yet we are still looking at them with not enough information to properly answer the question. So we take a very oftentimes conservative route. And so, which I'm not advocating we should be reckless, but clinical research might help us be able to kind of answer some of these more nuanced questions in patients.
I love your idea of getting women involved in clinical trial design. How do we get also, I think it would be so important to get our primary care, involved as well, particularly when we talk about, primary prevention or treatment of hypertension, treatment of hypercholesterolemia. A lot of times they're not referred to us, they're treating them, in their office. How do you do that?
Well, I think for me as a specialist, I recognize that they are under tremendous pressure to see many patients, oftentimes too quickly, to be able to get in something as noble as a clinical trial. Some of the suggestions that I would have is engaging our primary care physicians and advanced practice providers directly, and having them realize that there is a team of individuals in clinical trials that can support them. And so we take a hard approach. And so oftentimes I will go out to primary care sites and give a lunch and learn, talking about some of the newest opportunities for their patients to be engaged in clinical research, and point out to them that we have the resources to be able to, just make the referral, let your patient know there's these opportunities out there, and we can do the rest. And I think building that partnership is the key to success, because you're right, we're only seeing the very advanced cases or the tip of the iceberg. And if we really want primary prevention, we have to get into the primary care clinics.
Yeah, so important. And I think it's important to stress to our primary care that really clinical research is about improving outcomes and improving, these patients that enter clinical trials. There is so much oversight, and there is actually all of these patients tend to do very well, whether they get the placebo or the actual, kind of study medicine. Most of the patients entering clinical trials do better from the clinical standpoint. And I think your idea of partnering with primary care is just really makes sense. Anyway, Nicole, we have plenty of work to do. Women, heart disease, and the need for better clinical research and better treatment. Thank you so much, Dr. Laura, for your time. And have a great time joining the UAB and all of its challenges, and particularly living in two different locations.
Well, I'm happy to be a resident of Alabama, and Dr. Bouchard, it's been an absolute joy to be able to connect with you and other cardiologists in the community. So I look forward to many more conversations in the future.
Thank you very much. Appreciate it.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.